anesthesia. Uh, we'll be having one two basic views class on this, and it will be taken by Dr. Arup. Dr. Arup Ratan Michael, who is one of the senior consultants in Apollo Hospital, and one of the best T specialists that I ever know. Arup, take over
Mm.
to you. Please guide us.
Thank you very much, Monalisa, for your kind introduction. It's a pleasure and privilege to teach something to the students. I'm sharing my screen actually. Just getting here. What has happened? Has something gone wrong? I
I
can't
think,
share.
Dr. Ravi, you have to allow to share the screen share
I
more than
think
once, please.
something. Share enter screen is. Can you see me? Can you see my presentation? Hello?
We can see your
Okay,
presentation.
thank you.
You can see.
Because I can't see any of you. That's why. So
Yes.
I'm going to talk about the basic transfacial echocardiography. I was supposed to talk, but unfortunately, my apology. It's my fault that few of my clips and videos are not working at the last moment. So I'm sorry for that, but I'll try to do as much as possible with the whatever views I have. So basically, we have 28 views in transesophageal echocardiography, and at least 20 views are basic views. But as a basic learner, as I believe this class is mostly for the students and trainees uh, who have started their career in cardiac anesthesia, or someone has done maybe few months or few years, 2 3 years. And so basic views, whatever you should know, at least you should know those things I'm going to talk. The first view is this mid esophageal four chamber view. This is the basic most view we start with. I think few MD students also get to know about this view. As you can see, it's at the mid esophageal level. Any transesophageal echocardiography we can do at 4 5 levels. One is upper esophagus, then you put the probe down, you get mid esophagus, then slightly more down, then lower esophagus, then further down to get transgastric, and further deepest down to get transgastric. So I'll start with a mid esophageal views, and this is the mother view, mid esophageal four chamber view. As you know, all of you know, this is four chambers: left atrium, left ventricle, right atrium, right ventricle, in this view. And obviously, in between two atrium, there will be intraatrial septum, and between two ventricles will be interventricular septum. And obviously, between left atrium and left ventricle will be mitral valve, and right atrium and right ventricle will be um, tricuspid valve. And the leaflets seen here are A2 and P2 of the mitral valve. And this is the septum, this is the lateral wall. And next view, once you increase the angle to 90°, keeping the probe at the same position mid esophagus, we get around two chamber view. The fourth chamber has turned into two chambers. So basically this is left atrium and left ventricle, and this is the mitral valve. So what has changed is that the mitral leaflets, the scallops have changed. Here we can see A1, A2, A3, and P3. So these are the leaflets we can see in two chamber view. In fourth chamber, we could see A2 and P2, but in two chamber view, A1, A2, A3, and P3. And the walls seen here different. This is the anterior wall, and this is the inferior wall. You can see the apex of the heart, left ventricle, the best seen in this view. So to diagnose any clots or anything, any apical pathology, this is probably the best view. Next is the aortic valve short axis view. So still, we are still in the mid esophagus. So keeping the probe in the same level at 30-35 degrees, you can get the aortic valve in short axis. You can see three leaflets of the aortic valve. This leaflet is right coronary cusp. This cusp is right coronary cusp because it's towards the RVOT. This cusp is left coronary cusp because the left coronary is arising from here. This is left coronary cusp. The other cusp is towards the left atrium, so this is a non-coronary cusp. So this is the mediusesophageal aortic valve short axis view. You can aortic stenosis, aortic regurgitation, and other aortic endocarditis. So a lot of pathologies you can see here. Mediusesophageal RV, right ventricular inflow outflow view. From the aortic valve short axis view, slightly increase the angle to 45-50 degree, you get this view. You can see the right ventricular inflow, that's the tricuspid valve, and the outflow is the pulmonary valve. So this entire area, this is the right ventricular outflow tract, RVOT. And this area is commonly involved, in tetralogy of Fallot. You can see um, some obstruction in the RVOT, and this RVOT is commonly dilated in arrhythmogenic right ventricular dysplasia, which is a hallmark feature of the ARVC, the dilatation of the RVOT. So this is tricuspid valve, this is pulmonary valve, and RVOT in between. You can see the pulmonary artery catheter going wrapping around this RVOT, and this view is called the wrap around view also. And from there, they increase the angle to around 107, 110 degrees. We get a bicaval view. It's not a typical bicaval view I got, but this is the SVC here. This would be the IVC, and this is the right atrium. Obviously, this septum has to be intraatrial septum, and this is the left atrium. And basically, this sometimes in 107, 10 degrees, sometimes you can see a very narrower opening here, which is the coronary sinus, basically not the IVC. So for the ideal view, there should be SVC here, IVC here, and this RA here. And tricuspid valve should not be seen in normal bicaval view, but modified bicaval view. When you increase the angle to 135 degree, you can see more of the tricuspid valve here. And how do you recognize whether this is the IVC or coronary sinus? Ideally, the diameter of the IVC is more than the SVC. So the IVC should be larger than the SVC, but in coronary sinus, you can see it's a small opening here, and the SVC will be larger than the coronary sinus. So that's sometimes once we get confused whether this is a coronary sinus or IVC, this is the tricks. And mediusesophageal long axis view, and from there we increase the angle to 125 degree, 125 to 115 degree, we get this view. Same LV, you can see the left ventricular in the long axis, you can see the aortic valve also, and the walls are different. This is A2, this is P2, leaflet of the mitral valve, and this is the anteroseptal wall of the left ventricle. This is the intralateral or posterior wall of the left ventricle. And obviously, this is the aortic valve, this is the right coronary cusp, and this is either anterior, this is either left or non-coronary cusp. And any aortic pathologies, anything can be seen here. And once from the mediastinal views, we go further down to the to the stomach, and first view you get the basal short axis view. Basically, you can see the left ventricle in short axis at the basal level. That's why you can see the mitral valve opening here, and there the walls are so. This is anterior wall. This is the inferior wall, and this is the septum wall and lateral wall. So all the walls you can see here in this view, and I missed the transgastric mid papillary short axis view, where you should actually see the two papillary muscle. That is one of the most important views. I have I, I had to skip because my videos are not working. Sorry for that. And once we go further down and rotate the probe to the right, we get this IVC view and the opening of the hepatic vein. And the IVC is nowadays very important for the cannulation in ECMO, for cannulation in minimally invasive surgery, and we can put a pulse of Doppler here in the hepatic vein to see the degree of RV dysfunction or tricuspid regurgitation and all these things. And so, other views I unfortunately I didn't have, but I intend to show is that medius vagal descending thoracic short axis view, where we can see the descending thoracic aorta in short axis, and you can see any for giving any intra-aortic balloon pump, you have to identify the guide wire and balloon there. For in minimally invasive surgery, you need to confirm the guide wire there. And for any descending thoracic aortic dissection or gross calcification, all these things can be diagnosed in that view. And moreover, we can diagnose a pleural effusion in that view. The gross collection in the pleura can be seen just below the descending thoracic aorta. I'm sorry, I don't have that view because videos are not running again. And the one views again, mid esophageal level, I'll recommend is that mid esophageal ascending aorta short axis view, where you can see the ascending aorta in short axis and pulmonary artery in long axis. Any pathology in the pulmonary artery, main pulmonary artery or right pulmonary artery can be seen there. Any thrombus in pulmonary embolism, so that's a very important view. And in one upper esophageal, the basic view we should know at that upper esophageal aortic arch short axis view, where you can see the pulmonary artery again in long axis, and where you can take gradient and across the pulmonary artery, which is important, which is very important in after post tetralogy repair, to take the gradient across the pulmonary valve. So coming back to the four chamber view, um, just a second. Screen. Can I be a bit interactive? Are there enough students so that I can be interactive? Are there enough students?
Just a minute, also, we have another speaker, Dr. Orku Saha,
Yeah,
and
yeah,
he is one of the very brilliant students from IPGMER,
yeah,
the
yeah, yeah,
final year students.
yeah, yeah,
He
yeah.
is also have, I think, some of the tea clips. Orku, do you have
Excellent,
some tea clips?
Yes,
excellent.
ma'am. Am I
You
audible?
can, yes, you are audible.
Yes, yes.
You can share this along with us. I think that would be better. That would sort
Yeah,
of a
absolutely,
discussion. Yes.
absolutely. If someone has got clips, that is much better. So I'll stop sharing my screen, but we will be, I mean, having interactive discussions if needed be.
Yes,
Okay.
excellent.
And
Okay.
Nargo, please don't hesitate to ask anything if you need to, or any of the students. Please, you can stop us wherever you want to, and we want to be interactive.
Uh,
I think I've stopped my screens here, is it? Yeah. I think
Or
you can,
yes, also you can share your screen. Yes.
yes.
is it visible?
Yes,
Hello.
yes,
Yes,
yes.
yes.
Yes, yes. Please carry on.
Okay. So, starting with the views, I'll show that this is a current recommendation from the AAC guidelines. There are currently 30 standard views. It is divided in multiple levels in the mid esophageal, then transgastric, then upper esophageal, deep transgastric, and there is two new added views, that is the deep esophageal right ventricular uh, uh, right ventricular two chamber view and right ventricular inflow outflow view. So coming to the first one, this is a mid esophageal four chamber view. This is the basic starting view from whenever we are going for a T examination. Here we will see the all the four chambers, the two atrioventricular valves, the intra-atrial septum and the interventricular septum. And use of this view is for chamber size assessment, chamber function assessment, the valvular functional assessment for Doppler and color spectral Doppler and color Doppler assessment. we can use this view. And for we can also use for any septal defect, we can assess the position of the defect and measure the defect also from this view. So from this we will change the angle, multiplane angle to around 60 to 70 degree. We will get the and focus is on the left side of the heart. We can get this mediasophageal mid-commissural view. Here we will assess the leaflets of the mitral valve, and measure the annulus, the measured annulus of the mitral valve. From this, if we change the multiplane angle to the around 90 degree, we can get the mediasophageal two-chamber view. And this use of this view, we can see the chambers assessment, the chamber, the quantification of the ejection fraction. Any if we turn the probe towards left and withdraw a little bit, we can see the left atrial appendage also. For any, you can see that if any clot or any thrombus, we can see the left atrial appendage. And here there are
Just to
two.
interact, Orko, we can also measure the length of the LV. The length of the true length is from measured from this view.
Chamber dimensions can also
Yes,
be measured
the
from
length.
this.
So specifically, the length can be measured from this view only. Okay, next.
So now from that view, if you change the angle to around 120 to 140 degree, we will get the mediasophageal long axis view. The importance of this view, we can assess the mitral valve and put a spectral Doppler here also. We will see able to see the chamber sizes, the associated with any aortic valve pathology. And from this view we will get also get, if we remove the probe, withdraw the probe a little bit, we will get to the mediasophageal AV long axis view. The difference from the previous one is that here the focus is on the aortic valve, not, and in the previous image it was focus on the main focus was on the mitral valve. So in this AV long axis view, it is more important for any assessment of the aortic valves precisely. The measurements of the LVOT, the aortic valve annulus, and the sinotubular, sinus of Valsalva, sinotubular junction, and the proximal ascending aorta. So yes, and this view is also more acha. From this, if you change the angle back to around 30 to 45 degree, you will get the aortic valve short axis view. Here the main focus is on the aortic valve cast leaflets, and we'll see the morphology of the aortic valve. Morphology of the aortic valve, the other associated any pathologies with it, we can also see. Now, from there, we change the angle to little bit for 50 to 60 degree. The focus shifts towards the RV, the RV inlet and the RV outlet. Uh, the assessment importance of this view is for the assessment of the RV, especially the RV wall thickness, the measurement of the RVs for any location of the any VSD can be done by using this view. And if there is any tricuspid regurgitation or tricuspid valve spectral Doppler assessment, we can also secondarily we can also use this view. From there, if you change the angle, if you rotate the probe clockwise, and if you change the angle to around 80 to 90 degree, we will get the mediasophageal bicaval view. Here, the main focus is on the both the vena cava, the superior vena cava and the inferior vena cava, and the upper chamber is the LA and the lower chamber is the right atrium. It is more important for us locating the atrial septal defects. For it is also more important for any cannulation purpose. Okay, from here we uh, insert the probe little bit. Sorry, acha, uh, insert the probe into the transgastric plane. you will get the transgastric basal view at a 0-degree multiplane angle. Here the focus is on the left side of the heart, and the basal we are seeing the mitral valve from the LV side, and we can see the anterior mitral leaflet and the posterior mitral leaflets. And importance of this, we can do a planimetry for mitral valve area measurement. If we insert the probe a little bit more, we will get the mid-esophageal mid papillary sort or the LV short axis view. From here, we will get the to the all the chamber quantification. We can see the papillary muscles, and from there, if we move the change the angle to around 110 to 120 degree, we'll go to the transgastric long axis view. And importance of this, we can measure the Doppler assessment of the LVOT and the aorta. Now this is the transgastric two-chamber view. Angle multiplane angle is around 80 to 90 degree. We can see the subvalvular apparatus of the mitral valve. Now, if we change the angle to around turn the probe clockwise and change the angle to around 120 degree, we will get the transgastric RV inflow view. Now, this is the almost the last one. If we insert the probe in the maximum and anti-flex the probe, and we can get the deep transgastric 5-chamber view. In a this is the more contemporary of the transthoracic apical 4-chamber view. And this is the ideal view for any spectral Doppler assessment of the LVOT on the aortic valve, and for the stroke volume or cardiac output measurement. This is the best view. And in the upper esophageal plane, we can also have the upper esophageal aortic arch long axis view and the aortic arch short axis view. And in the aortic arch short axis view, we can see the RVOT and the pulmonary valve and the mean pulmonary artery. So this view is important for the assessment of the pulmonary valve and the stroke volume or the RVOT and the pulmonary valve spectral Doppler assessment. So this is a ascending out a long axis view, and this view is important for any location for while there is CABG. If there is doing the partial clamping, we can see the look for any aortic atheroma or any aortic dissection or something similar to this. This is immediate. Next to this, the left pulmonary vein view. From the mid-esophageal two-chamber view, if we rotate the probe anti-clockwise and withdraw a probe little bit, we can see the left-sided pulmonary veins just above the coumarin ridge, and we can do the spectral Doppler and color flow Doppler assessment from the left-sided pulmonary vein. And if we turn the probe extremely towards the right, we can also assess the right-sided pulmonary veins. These are right-sided pulmonary veins. So these are the two new views: the deep esophageal view or a deep esophageal. Mainly, this is for the coronary sinus assessment or a coronary sinus cannulation. If you do retrograde cardioplegia, this is the view for a tricuspid valve assessment for a transcatheter tricuspid valve procedures. This is the good view for going for a before going for a 3D. So these are the recommended views, and these are taken mainly from the AAC recent guidelines. Okay, so next to the this, I can say this is the next topic. I will want to say something about it.
Yes,
Uh,
yes.
Hello.
Yes, you can go on.
Yeah, yeah.
Also, it's a very good presentation. You
Carry
can
on,
go
carry
on.
on. Very good, very good. Carry on.
And just I want to ask one thing to you, that the tricuspid valve diameter can, from where we should measure the tricuspid valve diameter? Because this is very important, always
Tricuspid
asked by the
valve
surgeons.
Tricuspid valve measurement should be done in the four chamber, mid-esophageal four chamber view, uh, where the tricuspid valve, you have to insert the probe or withdraw the probe a little bit to see the maximal diameter of the tricuspid valve annulus in a more right-sided focused four chamber view, and the where the anterior leaflet of the tricuspid valve is more prominently visible. So in that plane, in mid diastole, that you have to freeze the frame and measure the tricuspid valve annulus.
Okay, very
And
good. Very,
we
thank
can
you.
also measure the anterior tricuspid leaflet, and it is because anterior tricuspid leaflet length is important if they are going for a tricuspid valve annuloplasty, and
Yes.
this is the view
How
recommended.
to measure it? How to measure it? The anterior leaflet length.
In a mid diastole, we can freeze the frame with the use of ECG. We'll have to freeze the frame and measure the anterior tricuspid leaflet length. And according to the length, the surgeon will decide the what size tricuspid ring is to be used for a annuloplasty.
Okay, okay. Thank you. Thank you very much. We can move on to your next. I think it's a problem-oriented discussion. What the problems we face in our day-to-day life doing to you, and what are usually asked questions that we usually face from the surgeons that we need to answer. So we can have the next discussion. Or please carry on.
Okay. Okay, so my next topic is use of transesophageal echocardiography to assist the surgical decision making in the operating room. So, as we all know, the transthoracic echocardiography is the basic modality of echocardiographic tool what we use before taking the patient for a surgical intervention or any transcatheter intervention. So in operating room, the transthoracic echocardiography is kind of not used as a good measurement, good access imaging tool. So esophageal echocardiography is mainly used in an intraoperative uh, setup, and these measurements are these things are quite important while doing more commonly doing surgical interventions. So my all these recommendations are taken from the this guideline from the American Society of Echocardiography. Uh, so firstly, I'll discuss the for mitral valve surgery. So for any mitral valve surgery, it is the for pre-surgical assessment. As we all know, we have to see the mitral valve anatomy, the mitral valve severity,
Orgo,
assessment of the mitral stenosis severity, the
Orgo,
mean
can you
gradient.
hear me? Orgo, just I'm
Hello.
interrupting slightly here. Do you have any cases with you, like the live cases, or whatever cases you did, practical cases with you?
Uh,
Because
Practical
we're
cases.
running short of time, I think. Practical cases with
No,
you?
sir. Practical cases, I have no, I don't have, sir.
Okay,
Practical
okay.
cases, I have just I just wanted to show the recommendations, and I'll share one or two of my experience what we have faced
Yeah, yeah.
during
That we want to know.
problems.
That we want to know whatever experience you faced, and then the decision has been changed after TOE. I mean, the patient was planned for something and has been, we have done something else. Please
Okay.
tell your stories here.
Okay. Uh, just like I'll go to this. This is the quite important thing for a mitral valve repair. Some of our patients we have the surgeons have planned for a mitral valve repair. So in intraoperative setup, the surgeon wanted to know all these parameters for a repair setting: the anterior mitral leaflet length, the PML length, the C-shape distance, the basal septal thickness, the aortomitral angle. All these things are important. So when the surgeon tried to for an intervention surgical repair, they have found quite problem to what kind of repair they can do, and what is the if the repair is viable or not. So these things are important. If we do we have to do measure all these things in pre-operative pre CPB setup and a post surgical setup. We have to see same things, and if these things we can see the repair is not viable, we have to tell the surgeon that the the repair may not be applicable for this patient. We have to go for a replacement. So, and same thing also, we have seen two cases for where the surgeon tried for a aortic valve repair. Here, repair is less commonly tried procedure in our setup. So the surgeon, in that case, surgeon wanted to see these parameters: the aortic valve annulus, the geometric height, coaptation height, the effective height, and the length of the sanotubular junction. So another common procedure is the CABG. CABG. So in CABG, sometimes what actually happens during the positioning of the heart, the hemodynamics parameter changes, and sometimes with the usual maneuvers, if we pushing fluids or starting inotropes and vasodilators, the hemodynamics still not acceptable. So at that time, if we have the we had the TE support, we had used the TE, we can see the acute obstruction of the RVOT. So we had to told the surgeons that please change redo the positioning of the heart, uh, and the hemodynamics improved. So these and we can I have seen last 2 days back, I have done a top case, so where the surgeon tried for a said that there is very minimal RVOT obstruction. He has put a Hager's dilator, so RVOT obstruction was not so clinically significant, so he tried to came out of CPB after repairing the VSD patch closure. So the patient did not came off CPB very easily. So it was a very difficult thing. So while I was doing the transesophageal echo, I showed the surgeon there is quite a chunk of muscle, and it was causing us very significant RVOT obstruction. And the surgeon had to go to CPB again, and he asked for a localization of the where is the proper muscle band is there. So he poked the RVOT from the outside of the heart and wanted to know is the where is the actual obstruction. So, and this was the image I have shown to the surgeon, and this was the spectral Doppler of that child. So again, the surgeon gone into pump and cross clamp, and he had shaved the RVOT muscles, and the child came out of CPB successfully with very minimal inotropic support, and the patient extubated on the after 6 to 8 hours. So in also we have also done very few ascending aorta replacement dental procedures. In that cases, the TE was quite helpful because transthoracic echocardiography report was not quite acceptable in the measurement parameters were not acceptable. So the surgeon, before planning for giving incisions, before surgical dressing and draping, the surgeon wanted to know all the parameters of the aortic parameters. Like for you had planned for the aortic, there was aortic aneurysm, and planned for the dental procedure. So all the aortic measurements were repair, and post repair he had done a valve conduit. So post repair he wanted to know all the parameters. So And post-marital valve repair, we had also post-marital valve repair, and we had also faced some HCM cases. Here we had seen these parameters, and surgeon had tried to shave off the septal muscle to some extent, and he had tried to came off CPB and asked for if there is any intracavitary flow acceleration in the LVOT, and if the shaving of the muscle is good enough. And so we had found that the shaving was not quite good enough. So we had told the surgeon we have to go to the CPB again and do the shaving of myectomy to some more extent. And successfully he had gone to the CPB again and did the myectomy procedure again, and we had come out of CPB and successfully discharged the patient. So these are kind of my experience. Uh,
Okay, very good cases and very good experience also.
Very good.
Arup, do you
Yeah.
want to add something?
Yes, yes. So, thank you, Orgo. Very good presentation, very good experiences. So, whatever you said, like the decision has been changed after TOE interop, but before the surgery actually begin, what are the few common things we miss sometimes, like a clot in the LV, any gross laminated clot in the apex of the heart, or in thrombus ball, or in a big clot in the left atrial appendage. So patient was posted for off pump surgery. Then surgeon has to change it to a on pump surgery, because with a clot in the LV, if you do a off pump, obviously that can be migrated. The chance of migration is much more. The other thing, after induction of anesthesia, if you say patient with CABG posted for CABG, and if you sometimes you find the AST, which is commonly missed in the transthoracic echo sometimes, then the decision changes. Say a patient is posted for a MICS CABG, but we found a AST, then it has to be a open sternotomy and CABG plus AST repair if the surgeon intends to. Or sometimes the surgeon will just leave it to MICS CABG and then a device later on. And the most common things we face for CABG plus minus MBR or AVR, sometimes you will find a moderate MR or moderate AR that is actually gray zone, and you need to carefully look at the pathology, why the MR and AR is happening and what's the degree. You need to increase the blood pressure and then see, and then take the decision, because it's a very important decision. Patient has come for a CABG and the patient lands up with another valve procedure which will mandate him anticoagulation for the rest of his life. So we have to absolutely cautious to take such decisions. That's why the pathology, why the patient has got MR is moderate or severe, why the pathology is very important to know. These are very common mistakes or common things we miss. And as per the European guidelines, two things you should not miss while you are doing the TOE. One thing is the clot in the left atrial appendage, and other thing is the AST or gross big PFO. These things you have to check when you are doing TOE. Mona Lisa.
Yes, yes, this is very nice. And another thing I want to ask, because some of the non-cardiac anesthesiologists are there, is there the utility of echocardiography, both transthoracic and the transesophageal, what they have to see before going to the non-cardiac surgery, like LUCS or any wrong non-cardiac surgeries? Because for every patients, we usually do echocardiography for all the patients, most of the patients. So can you guide us some little bit of important things that we should consider before induction of the patients, giving TA to a non-cardiac surgery or giving spinal?
Yeah, I think your voice is getting cracked.
Uh, am I audible?
Yes, now better.
No, I just wanted to just guide for the non-cardiac anesthesiologist. If before giving the anesthesia, either GA or spinal, before doing the starting the surgeries, what we should take taken into consideration from the echo report, because all the patients before non-cardiac surgeries have the echo report beforehand. So what to see except the ejection fraction? Usually see only the ejection fraction, not the rest of the report. So what is important before going into the non-cardiac surgery? What we should see?
Particularly if you're thinking you are going to do an echocardiography for whatever indication, the very important thing is the RV function for non-cardiac cases, because for most of the many of the cases are laparoscopic, many of the cases are orthopedic where they're going to use cement and otherwise on all everything can cause RV dysfunction. So if the patient has RV dysfunction preoperatively in these cases, and which practically makes the maintenance of the hemodynamics a bit difficult. You are doing an echo, that means, I mean, patient has got some concerns, poor heart or whatever, and on basis of the heart function, you can decide whether you're going to put an invasive lines, invasive arterial lines, or whether if the patient has RV dysfunction, they will put a neck line also for these patients. And for LUCS patients, RV function, particularly, see the fluid status is very important. PFO, sometimes all the embolism in orthopedic surgery happens through the open PFO. Those things are probably important. Then we can tell the surgeon that during CO2 inflation, we should not make the PCO2 so high, so much of high pressure on the intra-abdominal pressure that it really worsens the RV function.
Yes, very true. Madam is there. Madam.